Peter Schwartz. I'm the one you can see half in the picture if you're watching this online or later, or currently or later. I'm the interim director of the Center for Bioethics. I'm the director of the Bioethics and Subject Advocacy Program of the Indiana CTSI. And this is our 15th or something treats talk, which are the translational research ethics applied topics talks. These are supposed to be short. They're supposed to be introductory for people who are just entering the area of questions, or perhaps researchers who need some just-in-time type of advice. They're meant to be an introduction, so they're going to be short. Mr. Hosty will be short, 20 minutes or so, and then we'll have some discussion. And that's meant to be a quick introduction. People who have more questions, all of our treats talks are archived on the website of the IU Center for Bioethics and of the Indiana CTSI, and are available on YouTube. Jack laughs because he is the person who's responsible for that, as well as for some of the other archiving that we've done. If you have not been to the Treats Talks page recently, it's time to go and see the updates. We now have cleaned that up. There's additional information on there. It should be very clear finding the topics you want to watch. In addition, these are all now archived also under the Center for Bioethics Reference Center. This is work that, so just to transition here, I'll say, and if at the end of this, or of any of our Treats Talks, you want more information or more help, you can contact the resources from the Indiana CTSI, including our friend Chris Caldwell from the Indiana Regulatory Knowledge Support Team, or us at the Center for Bioethics at the Bioethics Subject Advocacy Program. All that information will be available, I think, at the end of the talk, and is always available on our webpage. Now I'm going to transition to talk about our speaker. This is Jack Hosty, who's a Bachelor's of Arts from Marian University, where he graduated a couple years ago, and now is a medical student at IU School of Medicine, and a MA student. So he's jointly enrolled in the bioethics track in the philosophy department master's program, which the Center for Bioethics helps to teach in. And so he's a second-year medical student now who spent the summer between his first and second year of med school with us here at the Center for Bioethics, having a good time and doing a tremendous amount of excellent work on our reference center, on topics we try to focus on, and on community consent. And so he actually helped construct our page, or actually update our current page on community consent. And at the end of it, we said, you know what, we've never had a medical student do one of these talks before, but now's the time. You are ready, and I have reviewed this with him. I think it'll be excellent, and we will go from there. And so with no further ado, I present Mr. Hosty.
Great. Well,
I think that was plenty of ado.
Yeah.
No further ado. There's tons of ado there. And ado is a French word for something, which we won't say.
Well, thank you so much for that introduction. It was awesome. So I guess to get right into it, so this is essentially a topic you could call community consent. The formal title for it is actually an exception from informed consent in emergency medicine research. And it's called that because it's not exactly informed consent. It's an exception to individual informed consent requirements. And so because of that, the way it's formulated, I guess, is you don't need to obtain this informed consent from all the individual participants, because this entire community has been enrolled in this study, and this is the community that might end up at the emergency rooms. And so the people living in the community who don't want to be a part of the study would have to opt out or verbally express to the study investigators explicitly that they want to get out of the study. And so it should be noted that this is used exclusively for emergency medicine research, and that would just be, situations where it would be impossible to obtain consent from the individual, like say if the person is unconscious and the researchers can't find a legal representative before starting this experimental emergency treatment. And so that would really be a situation where you can imagine, like, okay, how could we ever do research in this situation if we can't get explicit consent from these people who are unconscious? And so I guess to jump right in and give an example of a study where this was done before. So starting in 2003, there's this experimental blood substitute called polyheme. and it was being tested in this emergency situation of hemorrhagic shock. So obviously these people have lost a lot of blood, and so they're unconscious and they can't explicitly give their consent. And so the people in this community who wanted to opt out of the study would have to have requested a blue wristband, which would have been mailed to them, and they would have worn it, and that would indicate to the emergency healthcare team, especially in the ambulance, that they have decided to opt out of the study. And so, I guess the way the study was set up, the patients who ended up in an ambulance who needed blood due to their hemorrhagic shock, they were randomly assigned to receive either the experimental polyheme or real blood. And so the advantage here that everyone was all excited about with this polyheme study was that polyheme could be started immediately in the ambulance because there wasn't a need for blood matching. You wouldn't have to, you could just do it immediately. And so really the only option at that point in ambulances was just giving them saline to increase the volume of their blood. So that's why everyone was really excited about it. But this study had two phases to it. So the first part was this pre-hospital phase where they're in the ambulance and they're either getting polyheme or saline. And that's the situation that most people were really excited about. But then they also had an in-hospital phase, which tended to become the controversial part of the study, because once they were in the hospital and the emergency had subsided, the patients did have the option to tell the researchers that they wanted to opt out of the study and start receiving real blood instead of continuing to receive the polyheme. But if they didn't explicitly say that, the patients were continued on receiving polyheme instead of real blood. And so I guess you could see there might have been some issues with that. And so in order for a study, especially for like a drug or a device, to go through with community consent, they would have to meet the FDA's requirements for community consent. And so here I've listed all of the requirements for it. So just running down the line, the human subjects would have to be in life-threatening situations that necessitate urgent intervention. The available treatments would have to be unproven or unsatisfactory. And that stipulation right there might be the most restricting, because really what do you say is unproven, or what do you say is unsatisfactory, and how could we make something proven better if that's a stipulation to all of this? And then the collection of valid scientific evidence is necessary to determine the safety and effectiveness of the intervention. I think I would like valid scientific data for all of my to determine the safety and effectiveness of all of my interventions. So I think that's a good one. And obtaining informed consent is not feasible because the subjects are not able to give their informed consent as a result of their medical condition, i.e. being unconscious. The intervention must be administered before consent can be obtained from the subject's legally authorized representative. There's no reasonable way to identify prospectively individuals likely to become eligible for participation. So that's an interesting one. One situation I could see that being would be maybe an experimental procedure during childbirth in an emergency situation. So then you could just talk to women of childbearing age, really, and just get their consent rather than enrolling an entire community, because you don't need to be informing the men of the community of this study. Then participation in the research holds out the prospect of direct benefit to the subjects. And the clinical investigation cannot practically be carried out without the waiver. There's a few other requirements that they would also need to meet, like there would need to be significant community consultation. Usually that would be in the form of like a town hall meeting where they would have an open dialogue with the people who attended. And then there's the public disclosure of the details of the study, which is what is interpreted as one-way communication, stuff like advertisements using billboards and newspapers. And now there's even been a study that used social media. They used Facebook to get this information out there. And then the people will also need to be told how to opt out of the study. And to me, that's the most important requirement, because otherwise you've forced an entire community into research without actually giving them the option of choosing for themselves. And then lastly, the researchers are still required to make a reasonable effort to obtain consent from either the patient or the legal representative of the patient. And so there could still be some ethical concerns despite all this, all these regulations. And community consent is essentially this this term I'm going to coin here is informed revoking of consent. Because essentially, when you think about it, only those who are informed of the study are the ones who can actually opt out, because they're the people who are aware of what they can do. And those who are completely unaware of the study are still enrolled. And so there was one study that was analyzing all the patients who were enrolled in an exception from an informed consent trial. And they found that only 5% of the patients enrolled had actually heard about the study through these community consultation and public disclosure activities. And so that might, in and of itself, be something of alarm. I think that would be something we need to look into more to actually determine if that's how it is with a lot of these studies. But this one in particular, a very small number of people were actually made aware of it through what was actually supposed to inform everyone in the community of this study. And also another concern could be that the FDA requirement that researchers make a reasonable effort to obtain consent from the legal representative of the patient, it can't really be enforced effectively. It's more of like a good faith effort. So I could definitely see, especially in an emergency situation, that just being something that's not in the front of people's minds. And also, the criteria for which patients will be chosen for the study need to be strict and detailed, because otherwise the experimental treatment might be used on a patient who would have benefited from traditional treatment, and then in that case, you've then violated one of the requirements by the FDA. And the popular method of wearing a wristband to opt out of a study it's a barrier and a hassle, and I might have even understated it with that language right there. I mean, it's kind of a pain. You would have to get it mailed to you. You'd have to wait, and while it's in the mail, you feasibly could end up enrolled in the study, even though you opted out of it. And even then, like,
I don't want to wear it.
I don't want to wear it. Yeah, seriously. I was gonna say I didn't start wearing a watch until I got a Fitbit, and that was I wanted to see my own data and stuff. Like that had a utility to me. This wristband is just annoying. Like.
It's a reminder every day that you might be in hemorrhagic shock.
Yeah, exactly.
You put it on, you're like, oh, I'm not today.
Yeah.
I don't want to wear this thing. I hope I don't get.
I'd be like swatches too, so they match your different outfits.
Oh yeah.
Totally not okay.
Yeah. This is such a good point. Yeah.
Chris will tell us about other mechanisms people have used.
Well, I don't know. This doesn't happen very often.
Tattoos
So
on the
yeah.
forehead. Something else useful.
Yeah. Well,
Under your clothes.
Yeah.
Right. We talked about that.
Yeah, I mean, the other thing that's interesting, though, is Jehovah's Witnesses have a card they keep in their wallet to say, like, hey, don't give me blood. So it's like, okay, well, isn't that a model we could emulate? Like, print it at home, write it, sign it, and just put it in your wallet rather than wait for this wristband to come in the mail. I think it's like, I don't know why it became the norm, but that's what most studies are using now. And also another concern is that the requirements of public disclosure and community consultation are too cost prohibitive for most research. So yeah, that's actually a third dimension to this whole debate, is those people who don't like regulation. They just think it's restricting them from advancing medicine. And so just to tell you what happened at the end of the polyheme study, they got 720 patients, half and half, one half polyheme, the other half real blood. The polyheme group as a whole had a higher incidence of adverse events, which they called stuff like multiple organ failure, myocardial infarctions. And this was statistically significant, but probably in an effort to save face, they gave all this data to a blinded panel of experts, and they were unable to tell the difference between the two groups. And then there was no statistically significant difference in the 30-day mortality rates between the two groups, but the polyheme group as a whole actually did fare worse, but again, it's not statistically significant. 81 of the patients in the polyheme group violated protocol, which meant a lot of things, but it did include those people who decided to switch to real blood. The study's authors concluded that polyheme would not be used interchangeably with red blood cells, but rather when the likelihood of dying without oxygen-carrying replacement is so great that the potential life-sustaining benefit would exceed any potential risks. So here they're kind of backing off from what they hoped it to be as a blood substitute to something where they're saying, like, it's not as good as blood, but it's better than saline. And then at the end of, once they published all this, the FDA ended up rejecting polyheme's bid for approval in 2009, and they cited its worse 30-day mortality rate and higher incidence of myocardial infarctions. And of note, Wishart and Methodist were two of the sites that participated in the study with the approval of the IRB, and Northfield Laboratories filed for bankruptcy in 2009. They ended up spending 24 years and $220 million on all of this. And so then there were naturally a couple of ethical concerns with this polyheme study. The biggest one being in the in-hospital phase, once the emergency had subsided, instead of just switching over to blood, they kept those people on the polyheme. And so that wasn't really, I guess it'd be hard to make the argument that using real blood is unproven and unsatisfactory. So I think that was everyone's big deal, was like, okay, yes, using matched donor blood is definitely a proven and satisfactory treatment for people who have blood loss. So that was the big sticking point right there for a lot of people. But also during the community consultation and public disclosure of the study, Northfield Laboratories refused to reveal many of the details of the study, such as protocol methods, data regarding its efficacy from earlier trials, and they justified this by claiming it was proprietary information. And so this could raise the issue of this is lack of information necessary to even call something like this informed consent by the community. And so now I've got another example of a different study that's also using this community consent model, and the technique they're studying is called emergency preservation and resuscitation. And so it started in 2014, and it wants to test this experimental surgical procedure on patients with cardiac arrest from trauma. And so the researchers had similar community meetings and public disclosure. They offered the blue wristbands to be worn by those in the community who'd like to opt out. And the experimental procedure would only be tested on patients who arrive in such critical condition that their chances of survival are minimal. And so in the event of cardiac arrest from trauma, the traditional resuscitation methods we have are less than 10% effective. So I guess you could say that maybe that's teetering on unsatisfactory. The experimental procedure involves replacing the blood with cold saline, and they inject the cold saline into the thoracic aorta to induce hypothermia in order to slow down metabolism, which gives the surgeons up to an extra hour of time to operate. And so because of this injecting the cold saline, this is a device they created, and so that's why this is also under the purview of the FDA, and so it needed to meet the FDA requirements. And so this study is ongoing. There's no results published yet, but it's expected to be completed at the end of 2019. And so I guess to talk about the differences here between the two studies, the researchers in the EPR study were completely transparent during the community meetings and the public disclosure. They told them all about the procedure and which patients would be selected based on the inclusion-exclusion criteria. And these traditional methods are less than 10% effective, and this experimental method of inducing hypothermia is actually practiced very effectively in certain brain surgeries. And so I guess you could say that traditional methods are unsatisfactory, and this experimental method shows great promise. And also a very small number of patients are going to meet these criteria to receive the experimental surgery. The total enrollment for this study is expected to be 20, and it's only at 2 sites in Baltimore and Pittsburgh versus the 720 patients at 32 sites in the polyheme study. And that was actually another one of the complaints by the different IRBs in the polyheme study, was that they were having a really hard time communicating with the other sites about potential issues they were having, or just communicating really any ethical issues they had with each other. And so the take-home message you can take from this is that research in emergency medicine it's important and it's necessary for the advancement of emergency medicine. But sometimes informed consent is impossible to obtain in these emergency situations, especially if the patient is unconscious. And so the best method we have to respect informed consent and still conduct research in emergency medicine is to use this community consent model. It's certainly difficult to inform an entire community, but this is absolutely critical in providing the community with the information necessary to make a decision about whether they want to remain in the study or opt out of it. And perhaps we do need more involved educational methods, especially if only 5% of those enrolled had actually heard about it. And if traditional methods are available and effective, the experimental method should probably not be given. because this is an exception from informed consent, not informed consent. So that would be perhaps a different, you probably definitely need explicit informed consent for something like this, because the patient's life shouldn't be endangered for the sake of research, especially if they were unaware of even being enrolled in this study. And so if you'd like more information on this topic, you're in luck. We got a page for this on the center's website. So you can go check that out. There's a couple more resources. You can read more about the polyheme, the study, and all the controversies around that. And if you got any questions about this topic, or you need a consultation, go ahead, follow that link, or get in contact with Peter. There he is. That's the man you want to talk to. And also, there's the contact info for the center. There's my contact info. I don't know if you have any questions about this, or just wanted to know, I guess, what got me interested in it, or how I got into this. Go ahead, shoot me an email. And I got questions if you guys want to go, but we can save those for later.
Well, okay, leave these up. How about we leave these questions up? I assume we've got some comments from our in-person audience, and we actually, for the first time, we have a call-in option for, I'm sorry, not everybody can access that option because it's just experimental right now, which is some of the BSAP members who may want to call in and comment. We're going to try to make this more widely available for the next Treats Talk, where anybody who watches online can call in up to the level of our phone's availability. So right now, I guess I'll first ask for questions and thoughts from in the room. Anybody with questions or thoughts? There's some questions up here if you.
I'm interested in this cost prohibitive concept.
Yes.
Especially within the context of research that would be minimal risk.
Right.
So I can think of a lot of research that would be helpful and thoughtful and not really very dangerous at all, but would fall within IRB that would require consent. And so to do a public disclosure in that situation, it seems like the balance, there should be some extra category maybe.
Yeah.
What are you thinking of here? I'm just trying to get a sense.
Oh, I don't know. Like, what if you're doing research on the demographics of families most likely to present to a pediatric ER, and if you want to know whether single moms go there the most. And so really, all you're doing in that case is, I mean, there's no risk other than maybe loss of privacy, right? That's always the risk. And so everybody would be opted in.
So normally, since it's a survey, it'd be a consent process. There's no reason you couldn't consent the women coming to the people coming to the. And
There's
so
maybe a better example. I don't know.
And so the other thing to keep in mind is that this applies only to FDA regulated research, which is always greater than minimal risk.
Okay.
So if it's FDA
I missed
regulated,
that part, so
it's automatically greater than minimal risk, even if it's like aspirin versus ibuprofen. Even if it's relatively low, if it's FDA regulated, and you're seeking, this exception to consent, then you'd go through this. Otherwise, you could go through the typical waiver of consent, approval through the IRB.
I do think, I guess I'll just jump in. I hate to jump in early because I want to let other people talk, but this is generally the issue of why is consent required and when is it required? Obviously, it's a cornerstone of research ethics that patients participate voluntarily and with information about the risks and benefits of participating in the study. But this case presents this fascinating and very problematic issue of you can't do it. You just can't get standard consent, as Jack labels this thing. It's a study without informed consent, a study with something called community consent, which isn't really consent, as we've said. And so actually, I think of it as analogous to the pediatric case, right? The early ethical principles said you cannot do research on kids at all because, like Helsinki, I think said this, because you cannot get consent from children, and so you cannot do research on children. Eventually, there was a pushback saying, well, then how are we going to take care of children? Without the evidence, we're actually mistreating children, not treating them with respect. And so it's similar here. We say, well, how can we maximize care for trauma victims unless we have some way of enrolling them in studies without their consent, given it's not a setting where you can get consent. And so this is Jack's excellent talk, I think, really does highlight the way this has been done and then the problems with doing it this way. But Jane's comment makes me want to ask my question, which is, okay, it seems like given the many problems of sort of almost getting consent in this case, it seems like the solution is maybe no consent. Like why even, maybe this is a situation where since you can't get consent, but the data is important, maybe this is just a case where a community is enrolled in some other way. Maybe the community leaders should consent and individuals don't have an opt-out, or the opt-out is sort of minimal, I guess, as in these cases. Is this along the lines of what you were thinking, or what do you think about the balance here of trying to do better on the consent side, which you've raised some ways we might, versus maybe just accepting that consent is not going to be truly respected in this case, which is again very different from other cases where consent is waived, where it's a minimal risk. These are not minimal risk studies. What do you think, Jack?
Yeah, so even with all these FDA guidelines, it still is almost like a little like, it makes me a little uneasy. It's almost like a little unpalatable still, the whole concept. And so it's like, okay, well, if it's just the reality, then yeah, we might just have to be in a situation where it's like, you know what, like these requirements are restricting research. They're making it too hard, and we're not really solving anything because we're still not getting their consent.
So that's the thing, like the thing that I guess bothers me along with the idea of, the thing that bothers me is the fiction of it.
Yeah. Yeah.
Excellent.
Like if you've got 5% of people who actually know that this is going on. It was at the.
Yeah, that's the only data that I could
So why
find.
are we pretending?
Yeah.
That this is consent?
Yeah, exactly. And I think it's even like, it's an illusion, and even then, at times, it could just be taken advantage of certain uneducated populations because it's those who are proactive about stuff and very probably. I don't know. I don't want to generalize stuff here, but they might be of a higher intelligence who know of these studies that are happening in their community, and they're the ones that are going to be educating themselves about all of it and opting out if they don't like what they see.
Well, it suggests that what is important about consent is not informing the patient, but requiring some affirmative action on the part of the researcher, as if like their moral character is part of or their ethical, character is part of the research itself or something, and so that it seems sort of.
Let's get pushback. So we have a bunch of people saying, cut the BS. This is a non-consent study. I don't know if you're proposing getting rid of the current requirements or just accepting that they are minimal, right? It's accepting that the way it's written now, despite all the requirements that were listed in the talk, they are what they are. Only 5% of the population is going to know. Those who are motivated and informed will be able to opt out, but overall, let's face the fact that most of the community will not actually either pay attention or bother to pay attention, have the opportunity to pay attention to actually opt out and maybe confront that aspect. Maybe that is what is behind the acceptance of this kind of work. Just this idea that, well, it has to be there as an option, but let's face facts. It's not going to be a very real option for very many people, especially if there's a bracelet involved. I think that's one issue that you raised, Jack, which is I think very central. Is that the idea of requiring a bracelet seems crazy. If it's a study and somebody's bleeding out, I think the EMTs have a chance to go in the wallet and pull out a wallet. And now maybe they won't in a case, but that seems like a much better approach than requiring a piece of something to wear every day. Seems crazy.
So does I think it was really smart that you included also you didn't just vote the study after the polyheme one, EPR. The EPR study, including that is, I thought, a really good move. In the sense that you seem to be a little more accepting of how they did community consent in that way. And it kind of gets to what the actual study was, right? So it's like, we think we're actually comparing it to an intervention that hasn't been proven and we don't think is very effective.
Yeah.
Right? Or the standard of care at least wasn't that way. So it sort of makes me think that the regulations are actually good. It's an enforcement issue that's happening here. It seemed like the polyheme people, they weren't doing their best to inform the community. They were leaving out essential components that are necessary to do it. And the other part is I don't even know what the benefits of polyheme could have been.
Yeah, it was strongly backed by the military.
So I'll say more about this. I think you're right, Josh. So I think the idea in polyheme was if you are in hemorrhagic shock, you're a third year, so now you know you're a second year medical. So we have some medicine expertise in the room. We have a nurse as well. Chris, you're not a nurse, right?
No.
You're a lawyer. Oh, even worse. Two
Yeah,
lawyers,
I know.
2 lawyers, 1 nurse, 1 doctor, 2 medical students. This is a disaster. But if it was sick here, we wouldn't be good as EMTs at taking care of people, but we would be okay. So polyheme, the comparison here, I assume, is fluid resuscitation. So if you, or maybe it's just transport. I assume if you present actually, if EMTs want to call in and correct us. By the way, I do have a phone number for people who do want to call in. Gary gave it to me. There are open lines. 317-278-7008, the usual IUPUI number, 7008. And you can do the PIN 639-234-pound. That's 639-234-pound. In the future, we'll have it on the line or something. Anyway, so it would be that you either get fluid resuscitated with IV saline versus fluid resuscitated with this fake blood. And that seems like a case where you actually might have a good research question. This could be better to have fake hemoglobin in there than to have just saline. And so I assume that's the really interesting randomized trial. So if that's what you're asking,
and so I think Jack is right in saying, like, early on in the EMS setting, that it sounds like a good study. It's like once they cross the threshold of an emergency room and the ability to type and cross and get actual blood in there, or just like good blood in general, it's like, I'm not so sure anymore.
So are you saying, Josh, your concern is not so much, maybe more of a concern, but what happens after the emergency setting? Then it seems like the setting where they had a good argument was in the emergency setting.
Yeah, like in the ambulance, ready to go. The saline comparison, I think, is a little better than like actually having blood, because blood isn't that hard to get, right?
So do you think then that has to do with the military being involved with it? The military wants to know the longevity. How long can this person
they didn't do it for, there's a reason behind wanting to do it once you get past that, right?
Whereas the layperson doesn't need that.
Because the military setting is interesting because they're like refrigeration might be an issue, how much they actually have
how far
might
away
be an
they
issue.
are from the hospital.
Yeah, exactly.
Like in the helicopter for like
But
2
that
hours.
I'm going to say my thing here, which that does suggest, just like you said about it's an enforcement issue. So the concerns about consent are real, and we've addressed them, we've raised them. The concerns about study design are often sometimes forgotten by ethicists talking about ethics of research. We focus on consent, but actually in this case, it seems like the design itself is questionable. There seems to be a secondary purpose, this idea of continuing people in the hospital on polyheme, where requiring community consent for that seems to be only a useful way to get people in your study, not an actual requirement of the situation.
It doesn't meet the thresholds.
Not meet the thresholds. If this was approved by IRBs, I'm quite concerned about, maybe because I don't know details. Again, we're not a regulatory body here. We're talking about the ethics situation, the ethics issues of consent and study design. But it does seem like the polyheme study, my major concern is less with the consent in the emergency setting, but more the continuation of lack of consent, opt-out consent, in the hospital setting. If it's a military study, should be carried out in the military, right? I mean, it's like asking community consent to that, especially to do without consent in the hospital, without normal consent, seems like a problem. Chris is nodding vigorously. Am I wrong? I've heard there's some more of these studies being considered currently at IU.
There's one that I know of. The polyheme study is the last study I know of being done. That was done here.
I don't want to hear anything about studies that are under review. Of course, it's a confidential issue. Just that none of these studies are going away. Right, this is still an incredibly important topic for emergency medicine studies when you can't get consent, and we have this tremendous questions facing them.
And then, the issue of like how much did the community actually know, I think is a good one. But I'm a little less concerned, given that in traditional research consent methods, even individuals aren't that good, at least from what I'm aware of, at like being able to recall what happened. But that is a little different than like, I think those people could remember being given information, right? Like there's a lot of times where I'm given information, I don't know what it was, but I know I can think to myself, like in that time I remember thinking that that's okay, right? And so I rely on that. But this seems a little different in the sense that maybe it's like, was it 5% didn't even, only 5%?
5% were made aware of the study through.
Made aware of it.
Yeah.
Oh,
no. 5% of enrollees in the study knew about it beforehand. Said they knew about it beforehand. Now they may have heard about it and forgotten, but after they were enrolled in the study, 5% remembered knowing about it and not opting out. The other 95% didn't remember ever hearing about the study. From my sense of
Did
viewers.
anybody ask whether they would have been okay with it after the fact?
But were they upset about it?
would they have agreed to it ahead of time
Good
or
question.
opted out?
That's a good follow-up question.
Right? How bad is it that the 95% hadn't heard? If you ask them afterwards, do you feel you were mistreated because you didn't have a chance to opt out of the study? If none of them felt bad about it, that does, again,
You get the higher mortality rate, so there were at least a few of them that probably regretted participating.
Not a significantly high mortality. Jane is saying we only asked the living ones. In the Ronald Reagan tradition, she said, I've noticed one thing about the people you asked. If it's okay for them to participate in the study, they all survive.
Peter wants to fight because he's comparing me to Ronald Reagan.
Ronald Reagan famously said, of all the people who are in favor of abortion.
I noticed that all of them are living.
Okay. Other issues here. I was going to say another thing. So one of the issues I think you raised here is the issue of commercial interest and research. You know, one of the concerns you raised was the issue of proprietary information not being shared with the community. It's a transparency issue. There's also the concern here of when you ask a community to consent, i.e. to participate without consent in many cases, and it's advancing a commercial interest, that does seem to question the whole idea that commercial entity says, well, we're a commercial interest. We don't owe you anything. This is our data. You're actually asking the community to participate in this way. It seems like maybe there's a partnership there that should be respected or reflected in some way that maybe isn't reflected normally when an individual is being approached to be asked individually to decide about participation. So again, I think this does raise a lot of issues about community involvement in research that are really interesting and really in the forefront right now as we engage in things like biobank research, where entire communities are invited to participate. Admittedly, in that case, there's a form of consent for every individual, at least in current practice. Again, so once again, communities have raised the question, how fair is it, though, for us to be just the participants and not involved in the running of the study? So, for example, the National Precision Medicine Initiative, starting up now, has advertised and asserted and reasserted its commitment to the participants being true partners in the research, being involved in research design, being involved in the use of research results, being involved in direction of research, not just participants who are just being asked individually, but as a community of 1 million Americans participating in the Precision Medicine Initiative, which of course is a new world for research, where we don't ask our patients generally to run our studies, we ask them to participate in them. Okay? On time and under budget.
Yeah.
And advanced learning. Sorry, people on the phone, if you have any burning questions, again, please email us. We'll make sure to add that on to the page or respond to you personally. But that wraps up our next Treats Talk. We'll have another one near the end of September. Thanks for all for being here.